start the recording, and I would love if everybody who is not speaking could mute their at their end, put the mute on, and I'll have Reg start off and introduce what he's going to be doing. And first, I'll let people know who Reg is. Reginald Tan, if you don't, for those who don't know, is at St. Luke's Medical Center in Quezon City, just outside of Manila in the Philippines. And he has assembled a resident talk. They're going to be talking, and they'll tell you what they're talking about soon. But Reg, we dearly miss him. He was with us for a couple of years in Ottawa, and really got along great with everybody, and the team misses him very much. And we're it'd be great to see you in person, but this is the next best thing to see you on the video here. So thanks for allowing us to join together for these rounds, Reg, as we go through the various weeks. And I'll be setting up a bit more sophisticated email and social media system so that we can all keep abreast of what's going on. But these sessions will be recorded for distribution later on for those who could not make it or wanted to rehear some of the talks. And as we go on, every week there'll be a different international partner that we kind of join up with. So even if you're not on the roster, please join in at the various times, and it would be great to get your input and discussion. So Reg, without any further delay, it's all yours.
Hey, well, thank you. Thank you, Kasha, for giving St. Luke's the opportunity to share one of the cases we saw in the Cornea clinic. I want to congratulate you, of course, for the successful opening of your Cornea Center. So it's such a privilege to be trained under you, under the Ottawa program.
Thank you.
Thanks. So we actually have here Dr. Ruben Limbonchong. He's the head of the Cornea service in St. Luke's. He was the one who assisted you in the DMEC course last 2018. I'm not sure if you remember.
I remember. Hello.
Hi. Hello. Yeah. Hi. That's Erwin. Yeah.
And we have Dr. Erwin Chua, the head of the Eye Institute, or the chair of the Eye Institute. So to start off, we have here, so one of the most enthusiastic residents we have, Dr. Nicolette Chua, with a case. So she's going to share an interesting case we saw in the clinic. So there you go.
Hi. Sorry, I have to keep my video off because my laptop doesn't have a webcam. Can you hear me?
Yep.
Okay. Yes.
Okay, so good evening to all my mentors and colleagues from St. Luke's Medical Center, and to those in the Precision Cornea Center in Canada listening in tonight. I am Nicolette Chua, and together with my advisors, Dr. Ruben Limbonchong and Dr. Reginald Tan, I'm here to present an interesting case entitled The Struggle Against Graft and Rejection. We are presented with a 63-year-old male coming in due to blurring of vision of the left eye. Patient had already underwent penetrating keratoplasty twice. Initial indication was for pseudophakic bullous keratopathy in 2010, and then a repeat PK for graft failure secondary to graft rejection in 2017, who again showed signs of graft rejection 1 year post-op, with a VA of counting fingers at 2 feet, a hazy cornea with diffuse microcystic corneal edema. He then underwent his third penetrating keratoplasty February of last year. 1 month after the latest PK, Patient had a VA of 2200 uncorrected and 2080 pinhole with a clear graft and no dye uptake. Patient was maintained on moxifloxacin, prednisolone acetate, and sodium hyaluronate eye drops 4 times a day. At 2 months post-op, patient's VA was 2160 uncorrected and 2053 pinhole, noted to have non-pigmented keratic precipitates inferiorly. No other signs of rejection were noted. Assessment was to consider graft rejection of the left eye, and the plan was to increase topical steroids to every 2 hours for 1 week. On follow-up after 1 week, VA dropped 1 line to 2200 uncorrected and 2080 pinhole, with increase in size and number of non-pigmented KPs centrally and inferior paracentrally, with surrounding microcystic edema and anterior chamber cells grade 3 to 4. Hence, topical steroids was increased to hourly and started on oral steroids 60 milligrams per day for 1 week. However, the KPs persisted, so subconjunctival triamcinolone 0.2 cc was injected. Oral prednisone was tapered and maintained on topical prednisolone acetate Q1. 3 months post-op, VA improved to 2160 uncorrected and 2050 pinhole, with a quiet AC, a clear graft, microcystic edema inferiorly, and decreased KPs. Assessment at this time was a resolving graft rejection. After 1 week, however, the BCVA dropped from 2050 to 2080, noted to have fine, discrete KPs coalescing or forming patches inferior paracentrally and superinasally, with trace corneal edema, hence follow-up. Review of systems was unremarkable. Past medical history, patient has hypertension, benign prostatic hyperplasia, and secondary angle closure glaucoma. Patient has no history of autoimmune diseases or immunodeficiency disorders. Patient has underwent multiple eye surgeries on the left eye, such as ECCE with posterior chamber IOL implantation, the previously mentioned 3 PKs, AMED valve implantation, IOL explantation secondary to trauma, and scleral sutured secondary IOL implantation. There were no noted familial eye conditions, only hypertension, diabetes, and asthma. On physical exam, visual acuity of the right eye was 20/40 uncorrected and 20/25 pinhole. Visual acuity of the left eye was 2200 uncorrected and 20/80 pinhole. Intraocular pressures were normal on both eyes. External exam was unremarkable aside from a slightly hazy graft of the left eye. The right eye was unremarkable with clear cornea, deep anterior chambers, no dye uptake, and no cells and flare. The left eye had a hazy graft with trace corneal edema with fine discrete non-pigmented KPs coalescing to form patches inferior paracentrally and superinasally with grade 3 to 4 anterior chamber cells and sutures and IOL in place. On previous gonioscopy, all angles were open on both eyes with the exception of a closed superior quadrant on the left eye. And on previous fundoscopy, the right eye had a cup-to-disc ratio of 0.4 with intact rim, and the left eye had a cup-to-disc ratio of 0.7 with thin superior rim. The rest of the physical exam was unremarkable. For our salient features, we have a 63-year-old male with a chief complaint of blurring of vision of the left eye, who has underwent penetrating keratoplasty on the left eye 3 times for repeated graft rejection. There was no conjunctival redness associated. BCVA was decreased to 2080 from 2050, with extensive anterior chamber cellular action, fine discrete keratic precipitates forming round patches with surrounding corneal edema, which was refractory to topical, oral, and subconjunctival steroid treatment. Our main problem is that our patient has been having recurrent episodes of graft rejection over the past 9 years after 3 penetrating keratoplasties. The immune privilege of the cornea is the reason why the eye exhibits tolerance to a corneal graft and is recognized as an active process due to the absence of blood and lymphatic channels in the graft and its bed, leading to the absence of cells which generate the adaptive and cell-mediated immune response, and presence of some cells and peptides which cause an immunosuppressive environment for the aqueous. And because of an anterior chamber-associated immune deviation, suppressor T cells are developed which promote downregulation of the delayed type cellular immunity. The immune privilege of the cornea can be revoked by inflammation, infection, or trauma that induce neovascularization and lymphatic growth into the cornea as seen in the picture, thus permitting antigen-presenting cells to enter the stroma. Infection also induces pro-inflammatory cytokines that upregulate MHC antigen expression on corneal cells, resulting in an immune cascade leading to the eventual decompensation of the graft tissue. Corneal graft rejection is a reversible type 4 immunologically mediated process limited primarily to the graft, which occurs greatest in the first year and a half post-op, rarely within 2 weeks, but may occur as late as 20 years post-PK. It presents with sudden graft edema with anterior segment inflammatory signs in a graft that has previously been clear for at least 2 weeks. It usually starts at the graft margin closest to the blood vessels, with movement of inflammatory reaction towards the center to eventually involve the whole graft. The ones in red are present in our patient. Corneal graft rejection can be classified depending on the layer affected. So epithelial rejection, which accounts for about 2%, is usually seen in the early post-operative period, around 1 to 3 months, and begins as a line located near engorged limbal vessels, with migration across the graft-recipient interface. Usually, there is no associated edema. Subepithelial rejection is the least common. It is characterized by deeper infiltrates caused by rejection of stromal keratocytes randomly distributed in the central cornea, manifesting as Crackmer spots or white nummular dots, similar to that seen in adenoviral keratoconjunctivitis, and can occur along an epithelial rejection line. Endothelial rejection is the most common. It accounts for about 50% and is the most serious form. It presents with KPs beginning inferiorly at the graft-host junction and marching superiorly, forming the classic Huda-Dost line, with an AC reaction and stromal corneal edema in the area of damaged endothelium. The reported incidence of graft rejection after PK varies from 2.3 to 68%, depending on the preoperative conditions or prognosis of the case. So corneal graft rejection occurs more frequently with high-risk keratoplasty. There is no universally accepted definition of high-risk keratoplasties, but various reports in literature suggest that the recipient corneas can be divided into low, intermediate, and high risk. High risk is typically defined as deep stromal vascularization of the host cornea of 2 or more quadrants, or a previous graft rejection in the affected eye. So our patient is then classified as high risk. These are the risk factors for graft rejection, and the ones in red are present in our patient. I have then come up with the following differential diagnoses. So, an immune-mediated graft rejection, already discussed earlier, did not fully match our patient's presentation. The KPs and AC reaction and the corneal edema were seen too early in our patient at 2 months post-op, with a poor response to topical, oral, and subconjunctival steroids.
So, Nicolette,
Yes.
Sorry to interrupt. I'm not sure if you have time for discussion later on, but if you, it might be a good time to maybe pause here now that you've presented this excellent case and give a little background on perhaps some thoughts that some people in the audience might have on what's been going on, this differentials here. Is that okay, Nicolette? And then we can maybe resume.
Oh, sorry, what? Sorry.
Did you want to break for a few moments while we have some comments from the audience?
Okay,
yeah,
that's fine.
So I guess the question, Reg, if you permit me, is that I just want to see from the audience if any questions about the case. It seems like it's a very a lot has happened in this eye, from glaucoma surgeries, previous IOL work, trauma, and previous grafts. And so anything, when you were listening to the case, any thoughts as to what was going on or things that you were wondering about that you can perhaps ask Nicolette? I think it was pretty clear cut, Nicolette, then. And so, sorry, Dr. Minciolis, go ahead.
No, nothing to say at this point.
Oh, okay.
Yeah, I have a question.
Yes, go ahead.
Yeah, so how was the ocular surface of the patient? Was there any evidence of dry eye, or was there any evidence of ocular surface alteration, limbal stem cells?
So yeah, the question was, how was the ocular surface? Any issues with dryness or limbal stem cell issues, anything like that?
Patient has a bit of dry eye, but he was already maintained on sodium hyaluronate eye drops.
Okay. And yeah, I don't know if you mentioned this, but what was the immune status of the patient? Were they immunocompetent, compromised, anything like that?
Patient doesn't have any immunodeficiency disorders, or not known.
Okay. Okay, if there's no further questions, I will let you continue. Thank you very much, Nicolette, for the interruption.
Okay, so these will be discussed individually. So for anterior uveitis, it is the inflammation of the uvea, iris, ciliary body, and it can be caused by autoimmune diseases, viruses, or other isolated etiologies. Intraocular surgery can reactivate intraocular inflammation in eyes with chronic uveitis. It presents with acute onset of pain, redness, and photophobia, with anterior chamber cells, flare, KPs, hypopyon, iris nodules, synechiae, and is managed with topical steroids and cycloplegics. The anterior chamber cells and KPs in our patient may point to uveitis. However, symptom-wise and the presence of corneal edema and the poor response to steroids direct us less to a uveitic etiology. However, it cannot be totally ruled out. Another differential is an epithelial downgrowth, which is an aggressive, vision-threatening complication of penetrating intraocular injury and anterior segment surgery. It can be detected as early as 2 weeks and as late as 10 years, usually occurring 6 to 11 months after the initial surgery or trauma. In this disease, non-keratinized stratified squamous epithelial cells from the conjunctiva or cornea migrate through a wound and proliferate onto a variety of intraocular structures. Typically, the epithelium grows as a sheet proliferating over the cornea, iris, trabecular meshwork, ciliary body, lens, vitreous, and/or the retina. The ingrowth of epithelium incites profound inflammation and tissue damage. Here's another picture showing epithelial cells posterior to the iris. It is classically described as either a translucent cystic or membranous growth with a scallop border involving the posterior corneal surface or anterior iris in the area of the surgical incision, extending from the wound, clearly seen in the OCT image below. Sometimes it appears as a cyst or as cells floating in the anterior chamber. Risk factors include the following, and the one in red is present in our patient. Because this is a very rare complication and the acute presentation of signs in our patient don't match with that of an epithelial downgrowth, with no evidence of a membrane extending from the surgical wounds, this differential would be an unlikely one. For the diagnosis of an epithelial downgrowth, a spot of argon laser photocoagulation is applied to the area overlying the iris. If a membrane is present, the laser spot will cause the tissue to blanch and whiten, while laser applied to normal iris will result in a sharp darkened burn. Aqueous aspiration and cytologic examination can also be performed to assess for presence of free epithelial cells. Management of epithelial downgrowth includes injection of 5-fluorouracil into the anterior chamber, a large unblocked excision of any involved tissue, along with a full-thickness corneoscleral graft, and cryotherapy. Another differential is endotheliitis, which is defined as the inflammation of the corneal endothelium leading to disruption of endothelial function, causing subsequent visual changes. Its etiology is extensive and, although commonly viral, may be medication-related, procedural, fungal, zoological, environmental, or systemic. Corneal endotheliitis presents with eye pain, photophobia, and visual disturbance, and is characterized by corneal edema, presence of creatic precipitates, anterior chamber inflammation, and occasionally limbal injection, neovascularization, and coexisting or superimposed uveitis. On the basis of presentation of KPs, endotheliitis has been classified into 4 subgroups: linear, sectoral, disciform, and diffuse. So A is a picture of linear endotheliitis exhibiting linear distribution of KPs and is considered as the most serious form due to the progressive loss of corneal endothelial cells. B, this one, is a picture of HSV endotheliitis presenting with sectoral endotheliitis displaying disseminated arrangement of precipitates within the cornea and sectoral corneal edema. C is a picture of disciform and CMV endotheliitis and is distinguished by the disc-shaped edematous lesion located centrally in the cornea with precipitates distributed throughout the affected area. And D is a picture of diffuse endotheliitis presenting with uniform distribution of both edema and precipitates throughout the entire cornea. These presentations seem to more or less match that of our patient, which makes endotheliitis the more likely diagnosis. We will be discussing the 2 most common viral causes of endotheliitis, beginning with HSV1, which typically presents with a large disciform KP as seen in the photo. But this can also present as diffuse, linear, and sectoral KPs. It presents at around 40 years of age, and iritis and stromal edema are commonly seen, distinguishing this etiology from other causes of anterior uveitis. Elevated intraocular pressure is seen secondary to trabeculitis. HSV endotheliitis is common in individuals who are immunocompromised, and thorough history taking may elucidate prior or recurrent herpetic disease. Herpes stromal keratitis, or HSK, should be differentiated from HSV endotheliitis. So while both can present with stromal opacity, they are separate pathological processes. The stromal opacity in HSK is driven by inflammation within the stroma that is often accompanied by neovascularization or the interstitial keratitis, while opacity in the HSV endotheliitis is the result of secondary stromal edema overlying the KPs due to endothelial dysfunction in the absence of stromal inflammation or neovascularization. CMV-induced corneal endotheliitis usually manifests unilaterally among older males and contrary to other viral etiologies of endotheliitis and CMV infections in general, CMV endotheliitis is more common in immunocompetent individuals. It can present with corneal edema in the setting of linear or circularly organized or coin-shaped KPs, endothelial destruction, and a mild anterior chamber reaction. Intraocular pressure is often elevated at presentation, and coexisting anterior uveitis is not uncommon. HSV and CMV endotheliitis may be difficult to distinguish, and an AC tap tests for both. So both may present as disciform endotheliitis. However, larger disciform lesions are usually seen with HSV. CMV endotheliitis appears to carry a worse prognosis than other forms of endotheliitis, including HSV, with a higher rate of recurrence and a higher risk of graft failure. CMV is more common in immunocompetent individuals, while HSV in immunocompetent. For the treatment of viral endotheliitis, we can follow this algorithm. For a patient presenting with pain, photophobia, corneal edema, anterior uveitis, KPs, elevated IOP, and an AC reaction, which is unilateral, we need to review history of viral infections such as CMV and HSV, and perform an AC tap to be sent for PCR of viral genome. For a positive CMV DNA, we begin oral ganciclovir with topical corticosteroid and an addition of topical ganciclovir. While for a positive HSV DNA, oral acyclovir is started with topical steroid, and topical valacyclovir may be added. So back to our patient, who at 2 months post-PK had a drop in BCVA from 2050 to 2080, with fine discrete KPs coalescing to form coin-shaped patterns surrounded by corneal edema, and is refractory to steroid treatment. Based on our knowledge of the given differential diagnoses, our initial impression is now to rule out a CMV endotheliitis. An AC tap of 0.1 cc of aqueous humour was done to detect CMV DNA via PCR, which confirmed the diagnosis of CMV endotheliitis with 292,000 copies per ml. Ganciclovir or VIRGAN, eye gel 5 times a day, topical steroids 4 times a day, timolol twice a day, moxifloxacin, and sodium hyaluronate eye drops 4 times a day were started. So here's a little discussion on CMV endotheliitis. So as discussed earlier, CMV presents unilaterally among older males and immunocompetent individuals. And according to Alpha-WAS in 2013, corneal endotheliitis associated with specific coin-shaped KPs could be used as screening tool for CMV-related anterior segment infection, especially if associated with high IOP and corticosteroid recalcitrant inflammation. High IOP was not observed in our patient, probably due to his amide valve same eye. These are pictures grabbed from patients with CMV endotheliitis. The first picture shows localized microcystic edema evident on fluorescein staining. The second picture shows a scleral scatter photograph of the same patient, which distinguishes a stromal or epithelial edema lesions on the left side from multiple coin-shaped lesions pointed by the arrows. The third picture is from a different patient, which shows the presence of linear translucent opacities on the endothelium on higher magnification. In a study by Koizumi et al., corneal edema and coin-shaped KPs were observed in 73.4% and 70.6% of eyes, respectively, while linear KPs were noted in 8.3% and anterior chamber inflammation was detected in 67.9% of eyes with PCR-confirmed CMV endotheliitis. Here, we can see pictures from our patient showing microcystic corneal edema inferiorly on fluorescein and coin-shaped KPs already evident at 2 months post-PK. However, this was not recognized until the 3rd month post-op when it already looked like this. So in post-keratoplasty patients, CMV endotheliitis may resemble graft rejection because both present similarly. So Chan et al. Reviewed the histological findings of 48 cases of penetrating keratoplasty caused by failed grafts after a clinical diagnosis of graft rejection, and reported that the mean incidence of CMV infection in corneal graft rejection buttons was 6.3% per year. In a study by Chi et al. In 2013, where 7 out of 11 eyes with corneal stromal edema and KPs post-PK were found to be CMV positive. They found that in cases of graft rejection, KPs are characteristically found in the leading edge of the area of the edema, forming the Coude-Dost line, and all had vascularization of the cornea. On the contrary, in CMV-positive eyes, KPs are often concentrated in the area of edema in a coin-shaped pattern, with the absence of vascularization. Also, graft rejection is steroid responsive, while CMV endotheliitis poorly responds to steroids alone and improves with antiviral treatment. The relatively high incidence of CMV endotheliitis after keratoplasty can be attributed to several possible causes. First, patients who have corneal decompensation caused by pseudophakic or aphakic corneal edema, presumed HSV or VCV, and idiopathic endotheliitis for keratoplasty may actually unknowingly have CMV endotheliitis. Kandori et al. Found that 7 out of 29 or 24.1% of idiopathic corneal endotheliitis cases were positive for CMV. Second, these patients may have latent CMV infection in the cornea and anterior segment structures, and the use of immunosuppressants after keratoplasty leads to virus reactivation. And third, transmission of CMV from donor corneas into recipients may result in viral replication and infection after keratoplasty. For the pathophysiology of CMV endotheliitis, it was initially thought to be immune-related. However, current research suggests that it is an anterior chamber-associated immune deviation. So this requires puncturing of the eye with a needle and perturbation of ocular integrity, such as that during PK. So when an antigen, such as CMV, represented by the green circles, is repeatedly shed into the anterior chamber, when it is intermittently reactivated, it is taken up and processed by antigen-presenting cells that migrate via the blood to the thymus and the spleen. The source of these APCs is still controversial. Most studies say that these are resident APCs of the iris and ciliary body. In any case, these F4 AT-positive, CD11B positive ocular APCs migrate to the thymus and induce a generation of natural killer T cells, which in turn play a role in producing splenic suppressor cells. In the marginal zone of the spleen, the APCs emigrating from the eye also interact with various types of cells and molecules, helping to generate immunomodulatory cells such as CD8 or CD4 regulatory T cells, regulatory B cells, and natural killer regulatory cells, which spread throughout the body and induce antigen-specific immune deviation. which include the inhibition and initial activation and differentiation of the T cells into T effector cells, which lead to inhibition of the delayed type hypersensitivity. Moreover, it also inhibits T helper 2 mediated immune responses. In short, with the suppression of cell-mediated immunity and an intact or enhanced humoral immune response, the virus will be able to proliferate efficiently in the corneal endothelium, and infection occurs when the pre-existing antibodies are incapable of neutralizing the reactivated virus. Corneal endotheliitis is a clinical diagnosis following specific coin-shaped KPs, high IOP, and corticosteroid recalcitrant inflammation. Once a diagnosis is made, specular microscopy can be performed to support the diagnosis. Injury to and inflammation of the endothelium will reveal polymagatism and intercellular gaps, as well as pseudoglutate, as seen in the picture. PCR analysis of the anterior chamber aqueous through an AC tap is the current standard for diagnosis of any viral etiology. Because the aqueous humor is generally free from any pathogens, a positive result obtained by PCR should be considered reliable. An immunoassay indicated as IgM and IgG seropositivity via ELISA has been proven effective at diagnosing, but if negative, is not a substitute for an anterior chamber paracentesis. The presence of owl's eye inclusion bodies on confocal microscopy, as seen here, is diagnostic of CMV endotheliitis. This is the proposed diagnostic criteria of CMV corneal endotheliitis established by the Japan Corneal Endotheliitis Study Group. They defined that a typical CMV endotheliitis is a PCR-confirmed aqueous, positive for CMV DNA but negative for HSV and VZV, with corneal endotheliitis associated with coin-shaped lesion or linear KPs, and that a typical CMV endotheliitis is a PCR-confirmed aqueous positive for CMV DNA with corneal endotheliitis associated with corneal edema, KPs, and two of the following signs. So recurrent or anterior uveitis, ocular hypertension, and corneal endothelial cell loss. So the pictures on the right show different presentations of coin-shaped lesions of CMV endotheliitis. This is a study by Xiao et al. In 2018 to determine the prevalence and clinical consequences of CMV DNA in the aqueous and corneal tissues obtained at the time of corneal transplantation to evaluate the diagnostic value of PCR analysis in identifying patients at risk of post-keratoplasty CMV endotheliitis. So they gathered 30 patients who underwent corneal transplantation in 2011. The aqueous, excised recipient corneas, and donor corneoscleral rims were analyzed by PCR for the presence of CMV DNA. For the results, CMV DNA was detected in 3 aqueous samples, 8 recipient corneas, and 6 donor corneas of 30 patients. Post-operatively, 4 patients who had CMV DNA in either the aqueous or the recipient corneas during corneal transplantation were confirmed to have CMV endotheliitis. All patients who had CMV positivity in the aqueous developed CMV endotheliitis post-operatively and experienced graft failure eventually. Also, during the 60.5-month follow-up period, 4 of the 6 donor corneas containing CMV DNA failed, but only 1 patient who had CMV DNA in all 3 samples was related to CMV endotheliitis, concluding that despite the small sample size, it appears that graft-to-host transmission scarcely occurred. In the treatment of CMV endotheliitis, it should target both the infectious and the inflammatory components with systemic antiviral treatment and topical corticosteroids. Currently, there are no established guidelines for dosage and duration of treatment. The most common treatments include systemic valganciclovir, systemic ganciclovir, topical ganciclovir, or a combination of topical and systemic therapy. Combined therapy compared to systemic monotherapy appeared to be more effective in clearing the corneal edema and keratic precipitates, but this was not found to be statistically significant in a study by Koizumi in 2015. In general, patients with pure active CMV endotheliitis will start to show improvement of corneal edema within 4 to 6 weeks after initiating therapy. However, if corneal endothelial damage is severe, CMV endotheliitis often results in irreversible corneal endothelial dysfunction, which may need a regraft. Maintenance therapy in many previous studies involves systemic anti-CMV meds administered for 4 weeks to 1 year with clear grafts for a median duration of 21 months. Most of the studies treat CMV endotheliitis with systemic antivirals as main therapy. However, these two studies show otherwise. So on the left is a study by Koizumi et al., which used 0.15% ganciclovir gel topically 6 times a day for 12 weeks. And on the right is the study by Chen-Cha-Su, which used 2% topical ganciclovir every 2 to 3 hours daily as induction therapy and every 4 hours as long-term maintenance therapy. Although with only 7 cases each, both studies have shown that topical ganciclovir, whether the commercially available 0.15% or the reconstituted 2%, are effective treatment regimens to prevent CMV recurrence after PKP. Clinical improvement was seen at 4 weeks in all patients in the study by Koizumi. In both studies, endothelial functions were preserved with decrease in CMV levels in subsequent AC taps in all cases. No recurrence is seen in the study by Chen-Cha-Su, while there was 1 case of asymptomatic CMV re-emergence in the study by Koizumi. So I haven't found any studies comparing the efficacy of these two preparations. Maintenance therapy in previous studies mainly involved oral ganciclovir and valganciclovir administered for 4 weeks to 1 year. However, high recurrence rates after discontinuing the antiviral medications have been reported. The necessity of steroid use after PK puts the grafts at higher risk of CMV recurrence. Preparations of 0.3 acyclovir, 0.15 to 0.5% ganciclovir, and 0.5% valganciclovir gel have been reported as topical maintenance therapies. However, no information about recurrence rates have been documented. In this study by Anshu, 2 out of 4 patients had recurrence of inflammation after completion of treatment, with mean time to recurrence of 8 months. In the study by Koizumi, not shown here, 36% of cases showed recurrence after treatment and were placed back on respective anti-CMV treatment. Hence, a continuous antiviral medications is key to preventing viral reactivation and thereby preserving grafts in patients with CMV endotheliitis receiving PK. Further studies regarding this would be beneficial. for the clinical course of the patient, after 2.5 months of treatment, CMV was controlled. The VA was back to baseline at 2063. IOP was stable. Cornea was clear with no edema, with few pigmented KPs inferiorly. VIRGAN was decreased to 4 times a day with continuation of all other medications. At 3.5 months post-treatment, on VIRGAN 4 times a day, patient had stable BCVA, normal IOP, a clear graft with no edema, and single pigmented KP inferior paracentrally with no signs of graft rejection. Patient was maintained on VIRGAN 4 times a day, timolol twice a day, predforte, moxifloxacin, and sodium hyaluronate 4 times a day. Patient remained stable for 4 months on VIRGAN eye gel 4 times a day, still with the single pigmented KP inferior paracentrally. However, when the patient followed up at 8.5 months of treatment, there was note of new fine white KPs scattered inferior paracentrally with an elevated IOP of 28 millimeters mercury. We found out that the patient has been using a cyclovir ointment for 1 month instead of the ganciclovir gel prescribed to him due to financial constraints. Patient was started on topical ganciclovir eye drops 4 to 6 times per day made from reconstituted IV ganciclovir with distilled water, and was asked to find ganciclovir with 2% concentration. However, it was not commercially available, so instead was advised compliance to his VIRGAN 0.15% eye gel. After 1 week, now back on VIRGAN 4 times a day, there was significant decrease in the number of KPs, however, still with elevated IOP at 28 millimeters mercury. In thinking of a steroid-induced ocular hypertension, prednisolone acetate was shifted to loteprednol 4 times a day and was started on timolol twice a day. The pressure normalized the following week and timolol was discontinued. BCVA also improved to 2032. After 1 month, we are left yet again with the single pigmented KP inferior paracentrally. BCVA at this time was 2040 with high astigmatism on refraction, minus 7.25 cylinder at axis 22. And this was the last follow-up before our outpatient department closed last March due to COVID. Currently, the plans are to continue the medications, ganciclovir 0.15% eye gel, loteprednol, moxifloxacin, and sodium hyaluronate eye drops 4 times a day, to monitor IOP and restart timolol if still elevated, corneal topography to remove any tight sutures, a repeat specular microscopy, and ideally repeat AC taps until we reach undetectable CMV DNA levels. However, this may be very expensive for the patient to shoulder. So in summary, we need to remember that CMV endotheliitis can mimic graft rejection, so high index of suspicion for CMV endotheliitis as a cause of unilateral recurrent failed penetrating keratoplasty must be made, especially when the patient presents with coin-shaped KPs. It occurs mostly in immunocompetent hosts, and the standard for diagnosis is a PCR analysis of the anterior chamber aqueous humour. Accurate and prompt treatment should be ensued immediately after a confirmed diagnosis to prevent deleterious results. And therapy with topical ganciclovir combined with topical corticosteroid is effective in improving CMV endotheliitis. So the next time you see a coin-shaped lesion, you should
Toss a coin to your witcher, oh valley.
These are my resources. Thank you.
Okay, what a great presentation,
Wow.
Colette.
That was amazing. Nicolette, are you a resident or a fellow?
Resident.
What year are you in?
Second year.
That was fantastic. Truly, it was. That was a really nice, succinct, well-delivered presentation. I learned a lot. I have lots of questions. But I just want to say before we start the questions and discussion that congratulations. That was a very well done presentation. Your staff and attendings must be very proud to have you as one of their residents.
Thank you.
All right.
Yeah, we're more proud of her joke.
Any questions from the audience? I had a question actually while people are thinking of their comments and questions. Tell me more about this reconstituted ganciclovir drops that you use from IV solution.
Sorry, can you
Your IV antiviral that you reconstitute into drops?
Yes.
Can you tell me a bit more about that?
We made it 2%. So we used the vial of for the IV ganciclovir, and then got 0.2, and then added distilled water to make about 10 ml used as drops.
Okay. I have a question that's come up here. How long should we continue antivirals then if there's this issue of reactivation or the symptoms coming back and signs coming back? What would you recommend in terms of the length or duration of the antivirals?
There's actually no protocol yet, but in these papers I read, they usually do the repeat tap and then they discontinue when the tap is already negative for the virus. Mostly, the earliest that I have read, they discontinued the medication at 3 months, but they did a repeat tap to see if there was still the virus in the aqueous.
Okay.
Some studies have continued the medication until a year, actually.
A year, okay. Now, CMV endotheliitis was something that I think was known for a while in penetrating keratoplasty cases. When we started doing endothelial keratoplasties, so even 10, 15 years ago, we would sometimes have some interesting cases where it was relatively atraumatic surgery and then they kept on failing, and then we kind of clued in that it may be this entity going on. When you were doing your extensive research here, did you come across CMV endotheliitis with respect to endothelial keratoplasties?
There was, I think I read one study with DSEC.
Mm-hmm.
But there was only one study. Mm-hmm. There was CMV infect. The study had CMV endotheliitis also, but it was only one case.
Okay.
And I think the percentage of CMV endotheliitis in these cases are less than 1% usually.
Yeah, we have a few patients where we've done a second, third endothelial keratoplasty, usually DSAC, maybe one DMEC case, and it just unexplained reasons for the graft not doing well, and so then once we started doing testing and putting these patients on antiviral, the grafts behaved very stably and were very stable afterwards. So that's something that kind of translated into EK world as well, for sure. Any other comments from the group?
Yeah, I just want to have a quick comment regarding this case.
Mm-hmm.
So when I first saw this patient 2 months post PK, it was really hard for me to give a diagnosis of rejection because it wasn't really the typical rejection you see. First of all, it was 2 months. Usually we see rejection 3 months onwards, but 2 months is okay, cutting it quite close. So okay, maybe it's rejection. But then again, when you look at the cornea, it wasn't so edematous, and the vision was still around 20/80, around that range. When we see rejection, we usually, the vision usually counting fingers or 20/200, really bad because of all the edema. Well, in this case, it was, you see small KPs, and then the edema wasn't that bad, the vision isn't that bad, the eye isn't red or isn't really red. So, well, at first, basically we just treated it as rejection, for which it improved a little bit and then it got worse again. So, what do you do when you don't know what's the next step? So you just continue the medications. So that's what happened. It's good that the cornea team as a whole, they checked the case, like Dr. Ruben Limbonchong saw the patient and then recognized these coin-shaped KPs, and then gave the diagnosis of CMV. Had the AC tap done for PCR, and then we got the case and then we treated the patient. Patient went well, did well after. So I think it's if there are red flags to when you see a patient with rejection and then you're not quite convinced, it's always nice to have a new set of pair of eyes to see the case and then give their opinion.
Oh yes, that's for sure. That is for sure. Any other comments, last comments before we close out the hour? It's almost 8 o'clock. And any other comments, final comments?
Yeah, hi. Maybe just one comment on the treatment. Well, I was able to recognize it because I have had several cases of repeated graft rejection due to CMV and have treated quite a few of them. And the problem here now is because the oral or systemic medication is very prohibitive. It's very, very expensive. Okay, so for somebody who can afford it, there's no problem. My own private patient he was on it for a year, and then we shifted to topical, and he did quite well. In this case, systemic is very prohibitive, so we have no choice but to give him ganciclovir, but it's only 0.15. Okay, for topical ganciclovir, I think literature states that it has at least to be 2%. And then again, you can make that, you can reconstitute that from the IV ganciclovir. So looking at this case, it seems that it can be controlled by 0.15 ganciclovir, that's VIRGAN, but it seems that I'm not sure, because when we withdraw it, when we stop using it, it seems to recur. I'm not sure if we're underdosing him. Okay, so it's really maybe it's really, we really have to bump it up to 2%.
Yeah.
And get the PCR down the line. I think VIRGAN can control it, but I'm not sure it can totally eradicate the virus from the anterior chamber. That's my question.
Interesting. So the 2%, perhaps we should pay more attention to the 2% formulation then. Okay, thank you, Ruben.
Yeah, thank you.
Anything else?
So at this point, what is the specific indication for starting an oral antiviral when we suspect a CMV endothelitis?
So the question was, what are the indications now for starting oral antivirals for CMV endotheliitis now? What indications do you have?
Hello. So oral antivirals are actually the more studied ones. So that's usually the one given to these patients once you get a diagnosis, on initial diagnosis of CMV endotheliitis. And then we just, I guess Nicolette just found some studies saying that topical medications also work. Because again, we need to find other alternatives because IV medications are very prohibitive, or systemic medications are prohibitive in cost. But I think it's hard to get VIRGAN in Canada, right? It's special order. But I guess the hospital can still reconstitute from the IV.
Yeah.
That answers your question.
Although I haven't tried that, that's a great thing I should look into. Well, Nicolette, thank you again, and Reg, and your fellow colleagues and attendings, thank you so much for this great presentation. It's early morning for us and evening for you guys, but Nicolette, you have educated people in North America, South America, Europe, Middle East, and Asia about this. So we just got to hit Africa, unless there's someone that had missed us from Africa. But thank you so much. That was wonderful, wonderful presentation. It is recorded, so we'll be able to disseminate it and distribute it later on. But if there's no further questions, I'd like to wish everybody out in Asia a good evening, and here in North America, South America, a very good day ahead. So thanks again. Next week, we'll have the University of Montreal talking about keratoprosthesis. Dr. Mona Dagger's group is going to be discussing keratoprosthesis and the various evidence-based management that we have for that. So thanks. Have a great day, great evening, and we'll see you next week. Bye-bye.
Bye-bye. Thank you. It's great.
That was great, Nicolette. I really enjoyed that.
Thank you.
And maybe, in addition to having the presentation, like the audio, I may, with your permission, have the slides like in a PDF format also available to distribute.
Okay, I can do that.
Yeah, just make sure your name and St. Luke's and whatever is on the bottom, so whoever sees the slide knows where it's from.
Okay, I'll send it to Reg.
Okay, thank you so very much. Bye-bye.
Bye-bye, thank you.